Thank you guys for coming to our Friday medicine meeting. And today it's from the GIT liver unit of CMJAH. And we're going to be presenting on autoimmune hepatitis. Our speaker is Dr. Nida Siddiqui, who is a registrar and has a strong interest in autoimmune liver disease, like myself. And she's done some research in autoimmune liver disease. Her MMed is also has been passed and published in autoimmune hepatitis. So hopefully she'll give us some insight. It's not a common disease. I have a referral bias, so to me, it's quite common. But I think it's something that we need to know about. It's practical, and you can make good outcomes in these patients. Thank you, Nida.
Thank you, Prof. So I will be taking you through an approach to autoimmune hepatitis. Sorry, just there you go. So AIH falls under the category or the umbrella of autoimmune liver diseases. Some of the other autoimmune liver diseases are your primary sclerosing cholangitis, primary biliary cirrhosis, and IgG4 related liver disease. They can present on itself or they can manifest as an overlap syndrome, but we'll talk about that in a few slides. So autoimmune hepatitis is a chronic disorder. It is characterized by progressive immune-mediated destruction of your hepatocytes, leads to inflammation, cirrhosis, and then eventually liver failure. Represents around 4 to 6% of all your adult liver transplants in the United States and Europe, and a higher percentage of patients in South Africa in a tertiary care center were found to receive or require liver transplant for AIH. And of interest, I mean, like a burden of a liver transplant in the United States actually comes from non-alcoholic steatohepatitis, whereas we have noticed in South Africa that the incidence of liver transplant, not just for AIH, but for all autoimmune liver diseases is increasing. I think this is stuck here. There you go. Okay, so who gets it? Females, more susceptible to males, all ethnic groups, all ages, does have a bimodal distribution. There is increasing incidence and prevalence. And how do you get it? So in all likelihood, the predisposition to autoimmunity is genetic, but the liver specificity of this injury comes from your environmental factors such as chemicals, drugs, viruses. You have your antigenic peptide, which is presented in a class 2 antigen presenting cell. It is presented to your naive, undifferentiated T helper cell. So depending on the type of antigen and the presence of cytokines in your microenvironment, the T helper cell then goes on to differentiate into either T helper 1, T helper 2, or T helper 17 cells. And then they further induce cytokines, which are responsible for the inflammation and further the hepatitis. So interleukin 2, 4, 10, 13, tumor necrosis factor alpha, and transforming growth factor beta play a huge role in the pathogenesis of autoimmune hepatitis. And of note, they found that there was an increased expression of transforming growth factor beta on your inflamed liver, and the level reduces as your inflammation subsides. So these patients, they present most commonly with an insidious onset. It's very silent. They present by the time, like 1/3 of the patients have a cirrhosis by the time they present. And acute disease it's not as common. 25% of the patients can present with acute disease as well. AIH does have extrahepatic manifestations, which is mediated by humoral immunity. So you have your antigen-antibody complex, activates complements, triggers inflammation. So look out when you are examining these patients, look out for your arthralgias, arthritis, vasculitis, glomerulonephritis, a bit like lupus. And like I mentioned earlier, it can occur as an overlap with other autoimmune liver diseases. So the most common picture we see is a PBC, predominant picture with AIH overlap, but it does overlap with primary sclerosing cholangitis as well. So you classify autoimmune hepatitis based on the presence of antibodies. the age of onset, and the response to treatment. So type 1, it's the most common kind of type of autoimmune hepatitis. This is the most common type we see in our adult population. And it is associated with your ANA, anti-smooth muscle antibody, and anti-soluble liver antigen antibody. And this antibody is against the antigens it's found in your liver. It's called your phosphoseryl selenium tRNA synthetase. And it's actually highly specific for autoimmune hepatitis. And then the other two antibodies, the anti-nuclear antibodies, so they are found in the nucleus of the cell. So very non-specific, doesn't contribute to diagnosis itself. But high titers of ANA in combination with your anti-smooth muscle antibodies, which are directed against your vimentin, desmin, your smooth muscle fibers, that speaks more of type 1 AIH in the right clinical setting. Of note, asthma alone is associated with DILI, so we must be careful. We have to have the right clinical context, and the titers associated with ANA are important. Type 1 has a good response to treatment, but the relapse rate, and we will talk about it in greater detail, the relapse rate in all three types is very high. Type 2, less common than type 1, mostly presents in your pediatric population, and this is associated with anti-liver kidney microsome antibody. Anti-liver kidney microsome is basically directed against the antigens, your cytochrome 2d6. And this is also found in hepatitis C. So if you are suspecting autoimmune hepatitis and you do find anti-LKM1, you have to rule out hepatitis C to kind of have a definitive diagnosis of AIH. The treatment response here is variable, not as good as type 1, but they do require long-term maintenance. And then type 3, it's associated with your soluble liver antigens, as we spoke about earlier, and it has Rho52 antibody positive. So this is basically, Rho52 is an, what's it called, an antigen sequence, which binds to, it's an amino acid sequence, which binds to your single and double-stranded DNA. And a proposed theory here is that this actually happens in the virus, especially your Epstein-Barr virus. Then how we get it is through humans get infected and then molecular mimicry. And then, like I said earlier, this type 3 requires lifelong immunosuppression. So to consider some other differential diagnoses, AIH resembles acute viral hepatitis early in its course. Drug-induced liver injury is a major cause to exclude, and especially drugs which cause, like a lupus-like, which can induce drug-induced lupus. So your nitrofurantoin, methyl-dopa, isoniazid, minocycline. Wilson's disease. So in your adolescence, Wilson's disease will present with chronic hepatitis way before it will present with its neurological manifestations or your classic case of Faucher rings. And then some of the other, so it's an important thing to rule out here. And then obviously some of your others are primary biliary cholangitis, alcoholic hepatitis, non-alcoholic steatohepatitis, and cryptogenic cirrhosis. So this slide, it speaks to the dilemma of probable versus possible AIH versus are you dealing with a drug-induced liver injury? And we will talk about this probable versus possible just now in the next slide. But I see as a medical registrar, you often get this scenario where you get stuck whether it's AIH or whether it's the drug which is giving you a similar picture. And a very useful thing to do here is to try them in steroids. You get a good clinical response, you start tapering your steroids. If the patient relapses, very likely it's autoimmune hepatitis. If there is no relapse, likely it was all due to the drug, and all you have to do is just avoid the drug in the future. So this is the International Autoimmune Hepatitis criteria by the Autoimmune Hepatitis Group. This was released in 2008, and it is highly specific as compared to the first criteria, which was released in 1999. And I like it, it's simplified. It's only got 4 factors to deal with. So you have got your antibodies that we have spoken about, absence of viral markers, elevated immunoglobulin G levels, and histological findings. The classic is interface hepatitis. So just of note, this criteria is validated in a pre-transplant setting. All the studies for validation were done in our Caucasian population. There have been no studies to validate this criteria in our Black African population. And I'll tell you why I'm talking about it as we come towards the end and what we found in our study. But I think it will make a very good topic of research if we want to validate this criteria in our setting. But speaking of then the histopathology, the classic findings. So there in your AIDS, it's a chronic hepatitis. You can see mononuclear infiltrates. The classic feature for AIH is this. These are your portal tracts. You've got your lymphoplasmacytic infiltrate, and they actually infiltrate into your lung. So they infiltrate, and that is what's called interface hepatitis, which is pathognomic for autoimmune hepatitis. And then here in your slide D, you will see these regeneration nodules, emperipleuresis, which basically just speaks to that it is now regenerating. So the question here is that if we can determine the probability or possibility of AIH based on the simplified criteria we mentioned in the previous slide, do we need liver histology? We do. We do need liver histology for definitive diagnosis. Thank you. Because it's a silent disease and it often presents cirrhotic. So you're concerned about AIH, there is a diagnostic approach. You do your indirect immunofluorescence antibody tests. If one of them comes back positive, liver biopsy, AIH. If the test is negative, but your clinical suspicion is high, there are specialized immunoassays, especially for your liver kidney, microsome 1, and SLA, and Rho50. So to consider that. If they come back negative, you may be dealing with those 5% who have antibody negative autoimmune hepatitis. But if they can come back positive, you consider, diagnose, confirm, and then treat AIH. And your principles of treatment, you induce with steroids. And you maintain with a steroid-sparing agent. Aim is to achieve complete biomedical response. By that, I mean normalization of your serum transaminases and immunoglobulin G within 6 or after 6 months of initiation of therapy. And the aim is to reduce your long-term liver-related morbidity and mortality. So how do you treat? You have got a patient with AIH, you've confirmed, you start them on prednisone. You get a good response, you add your steroid-sparing agent. Currently, we are dealing, our first-line agent is azathioprine. If for some reason the patient doesn't respond or is intolerant to azathioprine, you go on to second line, which is currently MMF. And should the patient not respond to that, rituximab is used as a third-line treatment. So prior to you starting azathioprine, it is important that we check for our thiopurine methyltransferase mutation to prevent the adverse effects of azathioprine. And whoever attended Dr. Seabi's talk of late, she explained it very nicely. Just of interest, so in America, azathioprine comes with a black box warning. You can't use it without testing for TPMT. European guidelines are a bit more lenient. And in South Africa, I think if you have the TPMT mutation testing available, which we do have in tertiary care centers, we should use it. And so your treatment, you have to define endpoints of your treatment. Complete biomedical response is, as I mentioned earlier, it's the normalization of your transaminases and immunoglobulin 6 months after initiation of treatment. Insufficient response is a failure to achieve complete biomedical response within 6 months. A non-response refers to less than 50% reduction in your transaminases within 4 weeks or after 4 weeks of initiation of treatment. Remission is histological diagnosis. So you biopsy the patient and you look at the hepatitis activity index score. If it is less than 4, you can call the patient in remission. And intolerance is basically discontinuation of the drug due to any side effect or intolerance to treatment. So speaking a bit more about our remission. If you achieve complete biomedical response within 6 months of initiation of your treatment, you obviously continue the patient. You can continue, it's more like a physician's decision. You continue it for another year or 18 months. And then at some point you can consider, there's no timeline for remission. So at some point you can consider a liver biopsy. And if there are no features of autoimmune hepatitis, like no inflammation, the features we discussed earlier, no interface hepatitis, Then you call the patient to be in remission. But the question is, do you withdraw treatment? And I'm not so sure, because the relapse rate with autoimmune hepatitis is very high. The Journal of Hepatology reported relapse is almost universal after drug withdrawal. And a very recent study from Turkey in December 2023 showed 67% relapse rate within 19 months of stopping treatment. So this is a busy slide here, but basically you have a patient in AIH in remission, you stop the treatment, the patient relapses. You restart your treatment and it continues for life. So there is no further trials. If the patient stays in remission on monotherapy, then you can consider a liver biopsy. If your hepatitis activity index score is less than 3, try the drug withdrawal if the remission is maintained long-term follow-up. But if it is more than 3 or 4, then the patient requires permanent immunosuppression. And like this one thing which Prof always says, and he taught me through my MMed as well, is that you don't just look at the activity index. You have to read the histology. If things don't make sense, you have to speak to the histopathologist. You have to look for those features we mentioned earlier. But yeah, so relapse rate with autoimmune hepatitis, all kinds, is very high, and most of them require long-term immunosuppression. So we spoke that the first line treatment is azathioprine, second is mycophenolate, mofetil, and your third line is rituximab. But there haven't been any randomized clinical trials. That is, those are coming from the guidelines published by EASL in 2015. And this is a trial which was published in November last year in Journal of Hepatology, which actually showed that in treatment-naive patients, MMF with prednisone had a significantly higher rate of biochemical remission at 24 weeks, less side effects, and it had a superior tolerability to azathioprine. So, I mean, maybe this study, and perhaps we need a few more, and perhaps it is time for a new guidelines for autoimmune hepatitis, because a lot has changed since 2015 to now. And this is another study which is actually ongoing in Netherlands. It's a phase 3 trial, and they are looking at if MMF is better, can they not just introduce tacrolimus straight up after failure of first-line treatment? But this, we don't have the results yet. And then you have liver transplant for autoimmune hepatitis. So it is indicated in the setting of decompensated cirrhosis, failure, hepatocellular carcinoma. Survival rates in the European registry, they are reported at 1 and 5 years of 90% and 80% respectively. And we did a single center tertiary care study, and our one patient survival at 1 and 5 years are very similar to the European registry. But the concern was the graft survival, which was significantly lower in our South African study at 5 years. And it was so the patient survival was lower, but in our Black Africans, but not significantly as compared to the Caucasians. But the graft survival was only 55%. It was significantly lower as compared to the Caucasian populations. And what we found was that it was not so much the socioeconomic factors, but it was more that we, like what we got from the notes was that there was a real challenge to maintain or even induce immunosuppression post-transplant in these patients. And that might just speak to the genetics of AIH or the drug metabolism, something or the other. We still need to explore that. This is just the curve here, showing how poorly our African Black patients did they're grafted at 5 years. So the take-home points. Autoimmune hepatitis is rare. Elevated immunoglobulin, absence of viral hepatitis, presence of antibodies, compatible histopathology is needed for diagnosis. Your azathioprine is your first-line steroid-sparing agent, but there is increasing evidence for MMF to be considered as your first-line therapy. Liver transplant stays to be the definite treatment for end-stage disease, and early referral to liver clinic is appreciated. And thank